Hi, good day. My name is Dr. Sadiq Iwana, and today I'll be speaking about neurotoxicology. So, neurotoxicology is the science that encompasses the adverse effects of naturally occurring and synthetic chemical agents on the structure and the function of the nervous system. A neurotoxin is a naturally occurring or synthetic agent that can cause a functional or a structural change in the nervous system. And we look at a few neurotoxins today. We'd look at ethanol, opioids, cocaine, amphetamines, carbon monoxide, as well as paraquat. So we'll start off with ethanol. So the acute and chronic effects of ethyl alcohol or ethanol abuse on the nervous system or other organ systems are variable. In the acute setting, the primary effect on the central nervous system is associated with depression of neuronal excitability and impulse conduction, as well as neurotransmitter release due to the direct effects on the cell membranes. Now, we have a table here that shows the clinical effects associated with the blood alcohol levels. And we see that at 25 milligrams per deciliter, there is mild intoxication, altered mood, impaired cognition, and incoordination. Whereas at 100 milligrams per deciliter, there is vestibular and cerebellar dysfunction, increased nystagmus, diplopia, dysarthria, and ataxia. And at 500 milligrams per deciliter, it's usually fatal from respiratory depression. Now, in most jurisdictions, individuals with blood alcohol levels more than 100 milligrams per deciliter are defined as legally intoxicated. And a number of the states have changed this to 80 milligrams per deciliter. However, even levels of 47 milligrams per deciliter are associated with increased risk of involvement of motor vehicular accidents. And chronic alcoholism usually leads to increased tolerance in the habituated individuals. Survival with levels more than 1,000 milligrams per deciliter have been reported. In Trinidad, in our setting, as per our laws, it's 35 micrograms, in 100 mils of the breath, and 80 milligrams of alcohol in 100 mils of the blood alcohol. So, in terms of chronic alcohol abuse, we have Wernicke's encephalopathy. We also have cerebellar degeneration, which is usually due to the degeneration of Purkinje fibers in the cerebellar cortex, predominantly in the anterior superior vermis. There's also, we can also have central pontine myelinolysis, and there is also an increased risk of stroke, peripheral neuropathy, and skeletal myopathy. Now, usually in habituated drinkers, with the cessation or the reduction of the alcohol intake, there is compensation for the central nervous system depressant effects of the alcohol, which usually occurs in chronic alcoholism. So consequently, there is rebound central nervous system hyperactivity, which may result from fallen alcohol levels. Clinical signs of alcohol withdrawal are usually classified as either being major or minor, depending on the degree of autonomic hyperactivity and the presence or the absence of delirium tremens. And it could be also classified as early, occurring within 24 to 48 hours, or late, more than 48 hours. The signs and symptoms usually include tremulousness, hyperreflexia, insomnia, nausea, vomiting, autonomic hyperactivity, which are tachycardia and systolic hypertension, agitation, myalgias, and mild confusion. There's also an increased risk of alcohol withdrawal, seizures, which is classically seen in up to 33% of habituated drinkers, although there have been reports of it being in up to 75% of habituated drinkers within 7 to 30 hours of cessation or reduction of the alcohol intake. They typically consist of 1 to 6 generalized tonic-clonic seizures without any focality within a 6-hour period. And they usually occur before delirium tremens develop, although the risk of seizure persists for about 48 hours. Now, also with the withdrawal seizures, it's usually a single loading dose of phenytoin or dilantin is adequate for prophylaxis. However, since most alcohol withdrawal seizures are single, brief, and self-limited, phenytoin has not really been shown to be of much benefit in uncomplicated cases, and thus it is not indicated. It is usually indicated for patients with a history of previous alcohol withdrawal seizures, if they have recurrent seizures after being admitted, if there's a history of a prior seizure disorder unrelated to the alcohol, and if there are other risk factors such as having trauma or subdural hematoma, other factors that could precipitate seizures. Usually with these patients, CT brain and admission for observation for further or additional seizures or delirium tremens. We do this for patients who would have had the first withdrawal seizure, any patients with focal findings or focal deficits, if the patient would have had more than 6 generalized tonic-clonic seizures within 6 hours, and if there is any evidence of trauma. There are also perceptual disturbances or frank hallucinosis, which may occur early. Now, hallucinosis consists of visual or auditory hallucinations with an otherwise clear sensorium, which usually distinguishes this from the hallucinations associated with delirium tremens. And delirium tremens can occur between 3 to 4 days after the cessation or the reduction of alcohol intake. So, the prevention of and the treatment for alcohol withdrawal syndrome, we have mild alcohol withdrawal is usually managed with diet, supportive environment, reorientation, and one-to-one contact. Now, if these symptoms progress, now there is when we institute pharmacological treatment, which is usually benzodiazepines as the mainstay of treatment. The benzodiazepines all are effective. We tend to avoid any intramuscular administration due to its erratic absorption, and they reduce autonomic hyperactivity, and they may prevent seizures and or delirium tremens. Now, this table shows the initial doses which are used, and they are usually way higher than the doses that we use to treat like anxiety. And there are also adjunctive medications that we'll have to use with patients experiencing alcohol withdrawal syndrome, which will encompass correction of electrolyte and fluid disturbances, treating infection if they have pancreatitis, or correcting any dehydration. Other medications used for alcohol withdrawal syndrome include the drugs that would be useful for controlling the high blood pressure, either alpha agonists or beta blockers. We don't use the alpha agonists with the beta blockers. The beta blockers are also used to treat most tachyarrhythmias. Atenolol usually reduces the length of withdrawal and the amount of benzodiazepines required. We tend to avoid propranolol because of its psychotoxic reactions. Phenobarbital is an alternative to benzodiazepines. It's usually longer acting and helps prophylaxis against seizures. Now, a small study would have found that baclofen, and this was in 2002, found that 10 milligrams once a day for 30 days was associated with rapid reduction of the symptoms after an initial dose and with continued abstinence. Other supportive medications that we tend to use in these patients would be thiamine, which is given at 100 milligrams IM for 3 days. The rationale is that high concentration of glucose may precipitate acute Wernicke's encephalopathy in patients with thiamine deficiency. Right? We also give folate, 1 milligram for 3 days as well, once daily. And we also can give magnesium sulfate on admission, only really helpful if the magnesium levels in the blood are low. These reduce the risk of seizures, but we have to make sure that we ensure that the kidneys are functioning well and normal before administration. We also give B12 for the macrocytic anemia. We do not give these before folate because of the absorption. It's necessary for the absorption of the B12, of the folate, sorry. The multivitamins, if the patient is malnourished, and in terms of seizures, as we discussed before, phenytoin, we load with phenytoin 18 milligrams per kilogram, or usually 1.2 grams for a 70 kilogram person. Continued seizures may sometimes be effectively treated with paraldehyde if it is available. We look at delirium tremens, which usually begins, as we said, within 3 to 4 days of the onset of withdrawal, and it typically persists for 1 to 3 days. And the signs and symptoms include profound disorientation, agitation, tremor, insomnia, hallucinations, severe autonomic instability, and the mortality rate is usually 5 to 10%. It's higher in the elderly, but it can be reduced with treatment. Halidol and phenothiazines may control the hallucinations, but they lower the seizure threshold. So we have to be careful with use of these drugs. Any hypertension and tachyarrhythmias should be treated. Patients with delirium tremens. Now we'll take a look at Wernicke's encephalopathy, or Wernicke-Korsakoff encephalopathy, which presents as a classic triad of encephalopathy consisting of global confusion, ophthalmoplegia, and ataxia. These three symptoms of the classic triad are only present in 10 to 33% of the cases, and it's usually found in patients with thiamine deficiency. Usually the body stores of thiamine are adequate for just about 18 days. And we need to also take into consideration that this Wernicke's encephalopathy can be a result of these other conditions, such as hyperemesis in pregnancy, starvation, gastroplication, cancer, and hemodialysis. So the oculomotor abnormalities with Wernicke's encephalopathy occur in 96% of the patients, being nystagmus, a horizontal nystagmus, more than a vertical nystagmus, and the lateral rectus palsy, conjugate gaze palsy. The gait ataxia is usually seen in 87%, and it's due to polyneuropathy, cerebellar dysfunction, and vestibular impairment. And there are also systemic symptoms such as vomiting, fever, the inability to form new memories, memory loss, confabulations. In terms of imaging, a normal MRI does not rule out the diagnosis, but we can observe high signal in the T2 weighted images and the FLAIR images in the paraventricular or the medial thalamus, the floor of the fourth ventricle as seen in these pictures, as well as the periaqueductal gray matter of the midbrain. There can also be atrophy of the mammillary bodies seen on imaging. So Wernicke's encephalopathy is a medical emergency, and usually 100 milligrams of thiamine should be given intravenously or intramuscularly once a day for 5 days. IV glucose can precipitate acute Wernicke's encephalopathy in thiamine deficient patients. So, thiamine administration improves usually the eye findings within hours to days, and the ataxia and the confusion usually takes days to weeks to improve. Many patients that survive are left with the horizontal nystagmus, the ataxia, and 80% of these patients have the Korsakoff syndrome or the Korsakoff psychosis, which is a disabling memory disturbance involving retrograde and anterograde amnesia. Next, we look at opioids. Now, opioids, they act on the central opioid mu receptors and cause analgesia and euphoria. They can usually be quickly reversed with IV naloxone, which must really be available everywhere where opioids are being used. Examples of these are morphine, diamorphine, which is more potent and lipid soluble and metabolizes to morphine. We have fentanyl, oxycodone, and codeine, which the codeine, 10% of it is usually metabolized to morphine. These drugs, the opioids, usually produce meiosis, which is caused by the enhanced parasympathetic stimulation to the eyes. Now, the signs of opioid overdose, we have the acronym BLUE, where breathing can be very shallow, erratic, or completely absent in some cases. The lips tend and the fingertips tend to be blue due to decreased oxygen throughout the body. Patient may be unresponsive, decreased responses to verbal or to painful stimuli, and the eyes are usually pinpoint or constricted to an unusually small size. Overdose of opioids usually produce respiratory depression, hypotension, constipation, nausea and vomiting, cough suppression. It usually releases ADH, so we can have a syndrome of inappropriate ADH secretion and vasodilatation, which really precipitates the hypotension and the bradycardia. Fatal overdose may occur with any agent, but it's usually more frequent or tends to happen more with synthetic opioids such as fentanyl due to its high potency. And of course, there's a high addiction and tolerance profile with these opioids. So a test dose of naloxone, 0.2 milligrams IV, usually avoids sudden complete reversal of all opioid effects. If there's no significant reaction, additional 1.8 milligrams to give a total of 2 milligrams can be administered. And if needed, the dose can be repeated every 2 to 3 minutes up to a total of 10 milligrams. So narcotic withdrawal symptoms in opioid-dependent patients include anxiety or agitation, yawning, sneezing, piloerection, rhinorrhea, nausea, vomiting, diarrhea, abdominal cramps, and muscle spasms, all of which are usually just not comfortable for the patient, but they are not life-threatening. Clonidine may be helpful for some narcotic withdrawal symptoms. It stimulates the alpha adrenoreceptors in the brainstem, causing reduced sympathetic outflow from the central nervous system, and it decreases the peripheral resistance, the renal vascular resistance, the heart rate, and the blood pressure. With longer-acting opioids, especially methadone, repeated doses of naloxone may be obviated by the use of nalmefene, which is a long-acting narcotic antagonist, which is not appropriate for the initial treatment of opioid overdose. We'll next look at cocaine, which is extracted from the erythrocylon coca leaves. It usually blocks the reuptake of norepinephrine in the presynaptic adrenergic nerve terminals. All right. Cocaine usually has a very short elimination half-life between 0.7 to 1.5 hours and is extensively metabolized by plasma esterases and also by liver cholinesterases, with only about 1% being excreted unchanged in the urine. The half-life tends to be 1.5 hours in the blood, 1.2 hours in the saliva, and 4.1 hours in the urine. Cocaine usually is available in two forms: the cocaine hydrochloride, which is heat labile and water soluble, and it is usually taken orally or IV or by nasal insufflation. And there's the highly purified cocaine alkaloid, which is freebase or crack cocaine, which is heat stable but insoluble in water and is usually smoked. The peak toxicity for cocaine usually is 60 to 90 minutes after ingestion, except for body packers, 30 to 60 minutes after smoking, and if being smoked or IV injection within minutes. Now, the acute pharmacological effects of cocaine tend to, outside the nervous system, tend to be tachycardia, acute myocardial infarction, arrhythmias. You could have aortic dissection, abruptio placentae, hypothermia, intestinal ischemia, and sudden death. The Yeah. So the mental status is usually initially stimulated and manifests as a sense of well-being or euphoria, which is how the effects start. Sometimes there's this dysphoric agitation, um, but the stimulation is usually followed by depression, where there's paranoia and toxic psychosis, and addiction may occur. Pupillary dilatation or mydriasis is a key finding with patients on these drugs or with overdose, and hypertension from adrenergic stimulation as well. Now, the non-pharmacological effects related to the nervous system, we can have pituitary degeneration from chronic intranasal use, cerebral vasculitis, which is less common than with amphetamines, and seizures, possibly related to the local anesthetic properties of cocaine. There can also be an increased risk of strokes, be it hemorrhagic or ischemic or thrombotic, and we can also have anterior spinal artery syndrome. Now, there are also effects of maternal cocaine use on the fetus, which can cause the baby to be born with microcephaly or disorders of neuronal migration, neuronal differentiation, and myelination. The fetus could have a cerebral infarction, subarachnoid and intraparenchymal hemorrhages, and in the postnatal period, sudden infant death syndrome or SIDS. Most cocaine toxicity is too short-lived to be treated, as evident by the half-life. Anxiety, agitation, or seizures may be treated with IV benzodiazepines, that example lorazepam. Refractory hypertension may be treated with nicardipine or phentolamine, and IV lidocaine is usually used to treat cardiac arrhythmias, which are usually used to treat cardiac arrhythmias may cause seizures. Next, we look at amphetamines. Examples of these are methamphetamines, MDMA, psychoactive bath salts, or synthetic cathinone. Toxicity with amphetamines is similar to that of cocaine, but there is a longer duration, which usually is up to 4 to 12 hours of duration. It can be swallowed, taken IV intravenously, or smoked, as with ice or crystal methamphetamine. In the low or moderate doses, they tend to give symptoms of increased alertness, restlessness, talkativeness, irritability, insomnia, and hyperreflexia. However, in high doses, we see hypertension, tachycardia, mydriasis, agitation, delirium, psychosis. We even have seizures and hyperthermia. And in the prolonged use of amphetamines, we tend to have patients having loss of appetite, paranoid delusions, intense hallucinations, and toxic psychosis, where the treatment is usually benzodiazepines. Antipsychotic drugs such as Haldol or haloperidol should never be or should not really be used with amphetamines intoxication, because it also reduces the threshold for seizures, increasing the risk. We'll now look at carbon deaths per year in America associated with carbon monoxide poisoning. You about per year in the United States, in the US, usually cause oxygen delivery So we'll speak about carbon monoxide, which is termed the silent killer, usually responsible for is the largest source of death from poisoning in the United States, usually about 500 deaths per year. And the carbon monoxide poisoning usually causes impaired oxygen delivery and utilization, as well as the generation of reactive oxygen species. Now, monoxide diffuses rapidly across the pulmonary capillary membrane, and the elimination is dependent upon the degree of oxygenation and to a lesser extent the minute ventilation. So, carbon monoxide usually binds to hemoglobin, to the iron moiety of the heme and other porphyrins, with an affinity approximately 240 to 250 times that of oxygen, forming carboxyhemoglobin. This induces a allosteric change that greatly diminishes the ability of the other three oxygen binding sites in hemoglobin to offload the oxygen to peripheral tissues. This results in the deformation and a leftward shift of the oxyhemoglobin dissociation curve and compounds the impairment of tissue oxygen delivery, as seen here in the diagram. Now, only about 6% of these patients will show the classic cherry red color of the blood that is associated with carbon monoxide poisoning. The signs and symptoms they are based on the levels of the carboxyhemoglobin within the body. Where there can be none or mild, very mild headaches, going all the way to having confusion, seizures, or syncopal episodes, coma, or respiratory failure and death. And we have the levels or the percentage associated with these signs and symptoms. Of note, smokers may have carboxyhemoglobin levels of 15% without showing any signs or symptoms. Right? The signs and symptoms usually include headaches, which occur in 58% of the patients, nausea in 33%, dizziness in 29% of the patients, drowsiness in 14%, drowsiness and vomiting in 14%, coughing or choking 6%, confusion, shortness of breath, as well as syncope in about 5% each, respectively, and other symptoms such as throat and eye irritation, and chest pain and weakness tend to present in less than 5% of the cases. There also, I mentioned the generation of reactive oxygen species. Now, carbon monoxide results in a superoxide generation and oxidative stress, which likely contributes to the lipid peroxidation and neurologic injury. In terms of investigations, we have the EKG, which usually shows non-specific ST wave changes or sinus tachycardia. And in cases of severe intoxication, the CT brain or any imaging may show low attenuation in the globus pallidus, as seen in this CT here. Right? There's something called neuropsychiatric syndrome, or DNS, which includes variable degrees of cognitive deficits, personality changes, movement disorders, and focal neurologic deficits. It occurs in 15 to 40% of patients with significant carbon monoxide exposure, and it's reported to arise if there there may be coma, metabolic acidosis, EG characterized by lateralized sharp wave and focal electrographic seizure discharge within hours of exposure, And the MRI or the CT changes in one study, they noted the presence of MRI lesions after 1 month did not accurately predict subsequent outcome. Of note, suspected patients with carbon monoxide poisoning is usually suspected in patients, fire victims, patients with flu-like symptoms in cold climates, especially if the cohabitants of the household or pets are also ill, patients with unexplained altered mental status or lactic acidosis. And of note, the standard pulse oximetry is not useful and cannot screen for carbon monoxide exposure, as it does not differentiate between carboxyhemoglobin and oxyhemoglobin. Approximately 40% of these patients exposed to significant levels of carbon monoxide die. About 30 to 40% of them have transient symptoms and but make a full recovery, and 10 to 30% of these patients have persistent neurological sequelae, including carbon monoxide encephalopathy, which may be delayed in onset with the impaired memory, irritability, and parietal lobe symptoms. In terms of the white matter lesions, we have multifocal small necrotic lesions in deep hemispheres, extensive necrotic zones along the lateral ventricles, and also Brinker's myelopathy, which is usually a delayed leukoencephalopathy after a hypoxic episode. The symptoms of Brinker's myelopathy include apathy, dementia, Parkinsonism, agitation, urinary incontinence, and pseudobulbar palsy. And there's also the gray matter lesions. We have bilateral necrosis of the globus pallidus and lesions of the hippocampal formation and focal cortical necrosis. This is a flowchart in terms of how it is we could manage the carbon monoxide poisoning. If the patient the GCS is less than 8, we often intubate and ventilate. If the GCS is more than 8, we look for symptoms or signs of inhalation injury. So if there are burns on the face or the neck, if there is worsening neurological status, any respiratory distress or stridor or use of the accessory muscles, if any of these are present, we initiate the 100% normal baric oxygen and we obtain carboxyhemoglobin levels. The carboxyhemoglobin levels are more than 25%. There's loss of consciousness, altered mental status. There is where we consider hyperbaric oxygen therapy. Next, we look at PARPAT, which is also known in our population as Grammaxone. It's an organic beside, and epidemiological and neuropathological studies have shown that chronic exposure to PARPAT increases the risk of Parkinson's disease. It causes selective degeneration of dopaminergic neurons in the substantia nigra pars compacta, reproducing an important pathological feature of Parkinson's disease. Right? There's a study that was done by Wu et al., central nervous system damage due to acute PARPAT poisoning, a neuroimaging study with 3.2 TMRI. This study actually put application of MRI technique on patients with acute PARPAT poisoning, including the survivors. Since most of these patients tend to die, there's a high mortality rate. They only really were able to image 2 patients during the acute post-poisoning phase, and they noted that using the susceptibility weighted imaging, they documented changes in the corrected phase values for the extrapyramidal ganglia survivors, and these values correlated with excessive iron deposition. And their diffusion tensor imaging results were suggestive of microstructural changes in the extrapyramidal ganglia and the hippocampus, after Parkwood poisoning. So, patients with acute Parkwood poisoning usually have extensive damage to the lungs, liver, and kidneys, which usually is the main parts of the injury where it's most affected, but they also can show symptoms of central nervous system toxicity, especially in the patients that survive. These neuroimaging results provide an indirect demonstration that acute Parkwood neurotoxicity exerts a sustained effect during the acute and the recovery stages of poisoning. And that brings me to the end of neurotoxicology. Thank you, Dana.